For many, health is a given, but for some, life comes with unseen challenges. Behind every diagnosis is a story waiting to be told. When you live with a rare condition, the road to answers can feel endless.
On m'a de suite hospitalisée quand je suis rentrée. On m'a dit que j'avais un déficit immunitaire, mais on ne savait pas encore ce que c'était.
Il a fallu 6 ans que l'on me diagnostique mon handicap.
Yara's immune system isn't as strong as ours, so her body fights harder against diseases that our body doesn't really give that much effort to fight against.
Mi vida adulta teniendo una inmunodeficiencia primaria es una vida adulta como la de cualquier otro, solo que tengo que encargarme de otros tipos de responsabilidades.
To begin with, there are not a patient journey, there are many patient journey, because it very much depends on the patient, on the condition, on where you live, and on how you have been handled.
Join us and explore the journeys of people living with primary immunodeficiencies and those who work to make their paths easier. Primary immunodeficiencies, PIDs, also known as inborn errors of immunity, IEI, are a large group of rare genetic conditions affecting the immune system.
The immune system is that part of the body that fights diseases and keeps us together.
Meet Yara, living with a primary immunodeficiency and Down syndrome. Surrounded by her parents and 4 sisters, her daily life brings unique challenges and moments that reveal who she truly is.
She has a relatively lower immune system than the rest of us, or than normal, so she easily contracts diseases, and when she gets them, they tend to be more severe than if it were any one of us.
So our immune system is like our inner shield. So it protects us every day quietly from infections, from inflammations, from any kind of threats. So when a patient has primary immunodeficiencies, this shield that they have, this immune system that we have is not working well. There's a gap in it. So either they are missing a part of it or they are not working well, they are not functioning properly.
You can be affected by an immune deficiency whether you're a child or an adult, and whether you're male or female, and these are conditions that we see across the globe.
To better understand the PID landscape across the world, an important tool has been created with the support of the whole community.
We have the PID Life Index. And what is this? First of all, we began with the principles of care. We wanted to have key factors that are utmost important in a dedicated country to just understand the status of PID patients in this country. We gathered, to do that, we gathered a group of physicians coming from the world, patient advocates, and then we worked on defining 6 principles of care: diagnosis, treatment, coverage, patient groups, reference centers, and then registries. So at a glance you can have an idea on the status of every principle on a map. We also have a country page where one dedicated country can have every single information about the principles of care in the settings. And then we also have an access to IG treatment where you can see not what is available but what is registered in the country, because registered doesn't always mean available. We also have, and this is very important for many patients, the reference centers with mainly the addresses. And last but not least, we have a page for trials and research, where people having a trial or research in our field can ask us to just advertise this.
More than 4.8 million people are estimated to live with a PID worldwide. However, the majority remains undiagnosed.
J'avais 42 ans lorsque j'ai consulté un médecin. J'avais beaucoup de problèmes gastro-intestinaux, des douleurs abdominales, vomissements, diarrhée et fatigue. On m'a d'abord diagnostiqué d'une œsophagite jonctionnelle papillomateuse. 4 ans après, une endoscopie montre une maladie kystique de ménétrier, traitée par des corticoïdes, mais le traitement n'a pas été efficace. Puis un bilan sanguin fut en faveur de hypogammaglobulinémie qui a orienté sur le type. Il a fallu 6 ans que l'on me diagnostique mon handicap.
Patients with immune deficiencies are often diagnosed late, I think mainly because the awareness of immune deficiencies is quite low in the general community. So both within society, even within medical communities, many of primary immune deficiencies are rare diseases. So there isn't a lot of awareness amongst doctors who are not immunologists.
So for example, for the most frequent primary immunodeficiency, which are antibody deficiencies, it can be up to, the median diagnostic delay could be up to 6 to 7 years. It can also depend on where the patient lives. If the patient lives in a country where the awareness of immunodeficiencies is great, then this diagnostic delay can be reduced, and conversely, it can be higher in other countries.
Ce retard de diagnostic m'a fait perdre de nombreuses années de bonne santé. Ça m'a coûté une souffrance physique et une souffrance morale, avec répercussions destructives sur ma vie sociale et professionnelle.
An early diagnosis would be critical to avoid the development of organ damage, mostly of the lungs, but also of other organs such as the liver or the spleen or the gut or the kidneys. And in some other cases, we've seen patients who have had a shorter life expectancy because of a huge diagnostic delay. So we want to avoid that in the future. So during childhood, the main key signs to think of a PID would be mostly the recurrent infections. So that would be infections that could be like normal infections, or let's say looking like normal infections, but potentially having these infections very frequently, needing antibiotics, needing even hospitalizations. And in other cases, these patients can also have other features that could be non-infectious. So for example, severe allergies or autoimmune or inflammatory diseases, or what we call the lymphoproliferation, which would be mostly enlarged lymph nodes or liver and spleen. Sometimes there are other signs such as failure to grow or to thrive, consanguinity, and even other members of the family that can be affected as well.
The first time we saw a doctor, which was basically when she was born, the first thing we noticed and the doctor noticed was the Down syndrome. And Down syndrome comes with its own challenges. So she was put straight on oxygen and she was taken to the NICU. But after 2 days, they realized that something was wrong because she had breathing challenges and she was not premature. Yeah, so they decided to call in a pulmonologist. And when the pulmonologist came, that's when she said, no, it's not normal for a baby to have that kind of pneumonia that she had. And so she suspected that there was, that something needed to be done, like more tests needed to be done on Yara.
Most of these patients, we are not able to identify them without really doing a special test. But most parents know there's something wrong about the patient. But usually they are not able to put a label to it until it's a bit too late. And that's where the problem will come to primary immunodeficiencies.
I think it's important for everybody to understand. Out of 7 times she's gone to a hospital in the first year, for example, 4 of those have been near-death experiences, right? And you're just sitting and hoping because you don't know what's going to happen next. So for the first 3 years of her life, 70% of her visits we were unsure whether she's coming home.
The more severe forms of immune deficiency can usually present in childhood and present early on, and some of those conditions can be fatal if they're not treated adequately.
Newborn screening program is a simple test that can be done at birth. Usually it is done by taking a small drops of blood from the heel of a baby during the first few days of life. And through this simple test, it can detect severe conditions such as severe combined immunodeficiency or SCID. And this is very important because SCID, when these patients are born with it, they appear to be normal. But with time, this patient will deteriorate further, they become sick. And without identifying this patient well enough at the early age before they have this infection, the patient might not be able to survive.
For the most severe primary immunodeficiencies, like SCID, newborn screening is life-saving. It uses the same blood spot already collected in established newborn screening programs, making it just one additional test for many countries. Early detection makes timely, potentially curative treatment possible, giving babies the chance at a healthy life.
Adults with PID often present with infections. The most common types of immune deficiencies that we see in adults are problems with antibody production. And those conditions typically present with recurrent respiratory infections.
But as we learn more, we also identify new novel kind of primary immunodeficiencies that might represent a bit later. And in these patients, symptoms such as allergies, symptoms such as autoimmune conditions, these joint pains, or some fatigueness, skin rashes. Some of them might even have some organ defects. Their kidney might not be working well, or they might have problems with joint swelling. These might be some of the features beyond infections that might happen in patients at a later age that might point out that these patients might also be a patient with primary immunodeficiencies.
Fui diagnosticado con inmunodeficiencia primaria a los 16 años y actualmente tengo 25 años. Mi proceso para ser diagnosticado llevó aproximadamente un año con respecto a la lesión de la rodilla, la cual llamaba mucho la atención en los médicos, y cuando pasé por distintos sectores, entre ellos reumatología, les llamó mucho la atención los resultados y se pusieron en contacto con el sector de inmunología, los cuales llevaron adelante mi tratamiento y posteriormente mi diagnóstico de inmunodeficiencia primaria.
Knowing which gene causes a PID can make a big difference in a patient's journey. Genetic testing can find this gene by looking directly at the patient's DNA.
Our experience when it came to genetic testing, I think, was the advice by Yara's primary doctor to sort of understand why she is the way she is. Because psychologically it's also important for people to understand why. Because sometimes when you have other kids who are okay, and then somebody like Yara comes, you sort of ask yourself a lot of questions.
We need to keep in mind that PIDs are chronic diseases. So we face different situations. The more the patient know about their disease, the more they can cope with it.
The reason why we also pushed for genetic testing for her, which we did now, the whole exome sequencing, is because we also wanted to know which particular gene has the problem.
When a patient is diagnosed with primary immunodeficiencies, one of the most important things is to know what primary immunodeficiencies that the patient have, because it affecting a different part of the immune system. And in many cases now, we have treatment, we have management that we can perform in this patient.
There's a big range of treatments used to manage patients with primary immunodeficiency across life.
For example, in the form of immunoglobulin replacement therapy. So what we do is that we replace or we provide them with the missing antibodies. This works very well in patients with primary antibody deficiency. So we replace what they are missing. This prevents them from having frequent infections or any kind of problems related to it.
El tratamiento que recibo para tratar mi inmunodeficiencia es básicamente recibir gamma globulina por vena una vez cada 28 días. Y además complemento ese tratamiento con diferentes tipos de vitaminas y corticoides para tratar una inflamación del vaso y el hígado que son provocados por la misma inmunodeficiencia.
We also provide antibiotics. This will able to help them to treat the infections and in fact prevent that. And there are also medications where we're able to kind of regulate or kind of calming down the immune system. This come in the form of biologics or any kind of treatments where we try to suppress or kind of regulate the immune system.
Nowadays, there are a group of drugs coming on the market which we call targeted therapies. And these are usually drugs which can alter the immune system and often are used for very specific forms of immune deficiency. So they're not used in all patients, but they're used if we know exactly what the immune deficiency is and if it's suitable for this condition, for this treatment. I think going forward in the future, we will probably learn to use some of these drugs for patients even who don't have a known genetic condition, but at the moment, that's broadly not the case.
Alors j'ai été diagnostiquée quand j'avais 3 ans. Je revenais d'un voyage dans mon pays au Sénégal et j'avais perdu l'usage entre guillemets de mes jambes et on m'a de suite hospitalisée quand je suis rentrée. On m'a dit que j'avais un déficit immunitaire, on ne savait pas encore ce que c'était. Il y a eu un premier diagnostic et il y a eu une greffe de la moelle osseuse donnée par ma maman. Et après c'est comme ça qu'on a continué l'hospitalisation jusqu'à ce que je puisse guérir.
Hematopoietic stem cell transplantation is a procedure where in the patient with primary immunodeficiency, we try to change the defective immune system by replacing it with the cell from the donor, usually either the siblings or the parents. And by doing this, we're able to replace the immune system that was defective or missing to the one that is working well from the donor itself. And this provides the patients a new immune system that are able to fight against infections or any inflammation, so any threats. And this patient, in a way, will be cured from the underlying primary immunodeficiency.
Nowadays, there's a growing experience with using hematopoietic stem cell transplant for adults with immune deficiency. It is true to say that the outcomes for that are generally better if the patient hasn't accumulated a lot of problems related to their immune deficiency. So, for example, if patients have already chronic lung disease or chronic liver disease, that makes things like a transplant more difficult. But we are using this much more widely in adults now, and we're learning how to safely use these medicines in a broader range of patients.
Another kind of curative treatments that is currently quite new, but is kind of really promising, will be gene therapy. And in this case, which is available for certain type of PIDs, we actually taken the defective cell from the patients. We fix the faulty genes of in these cells, and we replace back these cells in the patients.
Up until now, because a lot of gene therapy has been done in clinical trials, a lot of those trials have been restricted to pediatric patients. So there are not a lot of adults who've had gene therapy. But there are new gene therapy treatments coming into trial now, and those will be available to adults in some cases, again for very specific genetic conditions.
Medical advances have made many PIDs treatable and some even curable. However, access to these therapies varies worldwide. Ensuring treatments are available in each patient's country and accessible through national health systems can help reach more people.
The global equity, the global access for this treatment are unfortunately not equal for all the patients, particularly in patients or in area where there are limited resources, either because the treatment is not available or there are those who are patients who are living far away from the hospitals.
For me, the hardest part for Yara's treatment is first the IVIG that she needed at that time was not in most hospitals. Maybe now it's different. Yeah, most hospitals are beginning to have it, but at that time the choice was within 4 hospitals, and most of these 4 hospitals are the more expensive hospitals. So that was a challenge.
My experience in trying to get Yara's IVIG was, initially we had local insurance, and one of the challenges was they couldn't cover Yara's treatment. Back then, the supply was not as much, but even then, nurses didn't understand how to administer it. This was a drug that was not covered by the state, and this is hardly even a condition that's known by the state, as well as in other parts of the world.
Mi preocupación sobre recibir el tratamiento es que no se dé en tiempo y forma, ya que el no recibir el tratamiento en tiempo y forma genera consecuencias severas para los pacientes, y muchas veces estos tiempos de demora no dependen del paciente, sino que dependen del Estado o la autoridad que se encargue de realizar esta vía administrativa.
So, despite that the technologies is now available for this condition, knowing that the access to this treatment are not globally equivalent to all the patients, it is something that doesn't sit well with me. This is why IPOPIFOD and all the other NGOs and all the other partners and the societies are working together to make sure this is not the case, particularly in the case of primary immunodeficiencies. Everybody, every patient, no matter who they are, no matter if they are Asians or no matter what race they are and which part of the world they are, they should have an equal access to the treatment that is available for this condition. I think this is what we are fighting for.
Managing this disease over a lifetime is essential, but access to care is not equal. Multidisciplinary care remains an aspiration in many parts of the world, and even high-income countries face gaps. One thing is certain: every patient needs proper care at every stage of life.
Cuando recibí el diagnóstico y el tratamiento, mi vida cambió para mejor, ya que yo de chico sufría demasiadas infecciones. Tenía infecciones recurrentes en el oído, que se llaman otitis, y con el tratamiento pude llevar un estilo de vida más sano, más cotidiano, y realizar actividades que en la adolescencia son importantes, como salir al exterior, salir, tener vida social.
These patients can get more infections than the average people of their age because they have an immune deficiency. However, they can go to school, they can go to work, and we strongly encourage this, provided that they have the best management, like antibiotic prophylaxis or immunoglobulin replacement therapy, the vaccinations that they should receive and their entourage should receive. Everything can be discussed with the PID specialist. PID patients usually have a multidisciplinary follow-up, which is absolutely critical. And the reason why they have such a follow-up is because they often suffer from different comorbidities or diseases or symptoms.
One of the main elements, if I may share, would be about listening to the patients, to the caregiver at the same time. What do they want at that particular time? What do they expect from the treatments? And what do they want to know about the disease that they have? And this thing changes throughout the journey of those patients. It changed when the patient was born, it changed when the patient grows as a child, it changed when the patient itself as a teenager, and definitely when they want to have their own family members. So the shared decision making happen on all part of this journey.
Yo inicialmente fui atendido en un hospital pediátrico desde los 16 años cuando recibí mi diagnóstico, y después mi transición fue un poco más compleja porque se dio en medio de la situación de la pandemia por el COVID. Entonces, cuando yo tuve 20 años, finalmente se terminó de completar el proceso de transición hacia un hospital de adultos, y ya ahí pasé a atenderme con un inmunólogo para adultos, haciéndome cargo de un montón de nuevas responsabilidades.
PID patients being chronic diseases, they will need to be transitioned from the pediatric care setting to the adult care setting when appropriate. So the transition care is a period of several years that would span usually from 13 years old to 22, 23 years old, and that would include the period in the pediatric care setting, but also the period after the patient has been transferred to the adult care setting. I want to stress the fact that there is no one-size-fits-all, and what we need to consider is patients' needs first, and what we as healthcare professionals can do to answer those needs, to provide resources for these needs the best way possible.
Cuando me enteré de mi diagnóstico fue un balde de agua fría porque no era algo que yo sentía que estaba relacionado con el motivo inicial por el cual consulté al médico, y además que implicaba un cambio rotundo en la rutina de mi vida, en el día a día, y además de que de todos esos cambios implicaba muchas dudas e incertidumbres de por qué se me detectó la enfermedad a esta edad, de dónde provenía, y un montón de dudas que obviamente llevan un tiempo responderlas. Atravesar una inmunodeficiencia primaria te hace pasar diferentes etapas en las cuales yo, por lo menos desde mi perspectiva personal, primero estaba muy negado con la enfermedad y con aceptarme a mí mismo. Yo solo quería encargarme de realizar el tratamiento, cumplir con el tratamiento y después desentenderme de la enfermedad hasta el próximo mes. Después a poco lo fui interiorizando y entendiendo que es parte del día a día y de la organización de la rutina.
So the transition period is usually a bit complicated, and sometimes quite complicated for the patient and also for the parents. And this is not only specific to patients with PID. And the reason why it is complicated is obviously because teenage years are usually a little bit more complicated in terms of, let's say, treatment compliance. More seriously, in other instances, we've seen patients experiencing avoidable hospitalizations, including ER visits or emergency room visits because of a destabilization of their treatment.
Le côté émotionnel, ça va, je trouve que je l'ai bien géré. Après, comme vous avez dit, quand on est dans la phase de l'adolescence, c'est un peu compliqué. Surtout que, on va dire, j'étais un peu différente des autres, étant donné que j'avais un retard de croissance. Donc j'avais souvent des remarques, des moqueries et tout. Mais en soi, ça allait quand même, parce que j'étais beaucoup entourée. J'avais mes parents, j'avais ma famille, j'avais mes petits frères. Donc franchement, ça va en vrai. Je me plains pas.
En mi caso personal, tener una inmunodeficiencia primaria me generaba problemas provocados por mí mismo, por no querer compartirlo con la gente que conocía o con mis amigos, mis círculos íntimos. A la hora de relacionarme sentimentalmente con alguien también, yo creía que eso iba a involucrar un problema o un peso para la otra persona, pero la realidad es que el hecho de tener una inmunodeficiencia primaria es una característica más, y la gente que realmente te quiere lo entiende y no va a conllevar un peso para ellos o un esfuerzo extra.
For example, here at Nicare we have this platform that is called La Suite, and that has been co-created with the patients with specific resources that the patients cannot have in their medical unit where they are followed up, so in immunology or in pulmonology and so on. So basically, when they come here, they'll, what we usually say, leave the diseases, at the front door. You come here as you are. You're a young man, a young woman. You need something that we can help you with, and we'll help you get more knowledge, more autonomy, more information, more empowerment, and also get a better self-esteem.
Yo creo que lo más importante para que la transición sea buena y lo menos conflictiva posible es una buena comunicación tanto entre hospital pediátrico o inmunólogo pediátrico e inmunólogo de adulto, como también una buena comunicación entre el inmunólogo adulto y el paciente. En mi caso particular siempre fue muy clave la comunicación con mi inmunólogo de adultos para que yo pueda entender bien cómo encargarme de mi enfermedad, obviamente desde otro punto de vista y haciéndome cargo de otras actividades.
I think that probably one of the things that I am most struck by in managing adults with immune deficiency is that you can't do it without good communication between the physician and the patient. So I'm actually going to say that I think the most important thing is shared decision making. That I need to be able to explain the medical side of things in a way that my patient can understand. I need to listen to what the patient actually wants for their life and their treatment. And there are different treatment options now, even, for example, in how immunoglobulin is given. And that needs a dialogue between me and my patient with immune deficiency to come to what is the best treatment for that individual patient.
Recibir el tratamiento de forma constante y estable cambió mi vida para bien. Yo pude realizar todas las actividades que quise llevar adelante cuando era más chico, de actividades físicas, actividades sociales. Me permitió poder estudiar una carrera en tiempo y forma, a pesar del cansancio o los inconvenientes de tener que combinar las fechas de tratamientos con exámenes y demás. A pesar de todo eso, siempre pude mantener esa constancia para obtener buenos resultados y llevar adelante un estilo de vida normal.
So I think managing life is actually just a really important part of discussing your condition with your clinician. So absolutely, when patients have big events coming up, like a trip abroad, I have young adult patients who want to go and travel the world for 6 months or a year, or they want to go and study abroad for a year. That's something that we just discuss in advance.
Et à la retraite, à l'âge de 64 ans, les voyages ne me sont plus des obstacles, mais toujours avec précaution, le masque est nécessaire.
In the UK, where I practice, adult immunology is an established specialty. Different healthcare systems have got different ways of looking after adults with immune deficiency. In some countries, there's very little or no provision for adults with immune deficiency. In some countries, they're looked after by pediatricians or maybe by rheumatologists or hematologists. I think that it is really important to have adult physicians with specific expertise in managing adults with immune deficiency. And that's for a number of reasons. One is because these conditions are rare. So you do need to have people who are trained in this particular specialty, can recognize patients and manage enough patients to manage patients well. The other thing is that adults with immune deficiency are not just big children with immune deficiency. In fact, some conditions only present in adulthood and can be a bit different to the immune deficiencies that present in childhood. And adult patients develop many problems in adulthood that you see in adult medicine that you never see if you're a pediatrician. So I think you do really need specialists who are focused on adults for both of these reasons, if we want to achieve the best outcome for patients.
El tema de ser padre teniendo una inmunodeficiencia primaria es un tema muy reciente que problematicé y pensaba, y creo que es algo que no me genera un problema después de haberlo pensado por mucho tiempo, y que además la ciencia y la tecnología va avanzando a un ritmo en el cual yo no sé cuál va a ser el estado para el momento en el que yo decida ser padre, pero lo que sí tengo claro es que el hecho de tener esa inmunodeficiencia o poder transmitir esa inmunodeficiencia que no sea un impedimento a la hora de la elección de ser padre.
Patients with PID can have a normal pregnancy and have a normal offspring, which I think we should really spread the message about this, because I've heard some patients wondering. We and others have published results that show that pregnancy are feasible, are possible, are safe, and the offspring is usually doing very well. The only factor that matters is really to adapt the treatment.
So anybody on immunoglobulin therapy needs to have their levels monitored, because in the last trimester of pregnancy, the trough levels tend to fall and the woman can be at risk of infection. So therefore we tend to increase immunoglobulin in the last trimester of pregnancy. It's also an important thing to discuss family planning ahead of time, because it's possible that some patients, some women are on medications that are not safe to take if you want to have a baby. Management of infections during pregnancy can be more challenging because there's quite a lot of the oral antibiotics that we can't use in pregnancies. I think it's fair to say that for adults with immune deficiency, it's still the minority of patients who have a known genetic cause for their condition. For anyone with a known genetic cause, absolutely there needs to be genetic counselling, because patients need to know how likely it is that their baby will inherit their condition, what will that mean, and then what are their options in their pregnancy to diagnose that, or even before pregnancy to know that. And for patients where there has been a genetic diagnosis looked for and not found, that's much harder.
Je pense que le fait d'atteindre l'âge de 75 ans relève du miracle grâce à l'avancée de la science médicale et de l'acharnement positif de certains médecins passionnés, consciencieux et compétents. Je me sens chanceuse d'être née en cette période où les chercheurs ont pu trouver un traitement efficace pour le DIP, afin de cohabiter avec la maladie, d'avoir confiance en moi-même, car garder un bon moral assez haut représente la moitié du traitement.
Patients are living longer, we're following our patients for longer, and they are living into older age. So now we're asking ourselves exactly these questions. Are there specific things that we should be doing for our patients to help them to live well into older age that are different from what is done for somebody else in their situation without an immune deficiency? I think there are a few things we do understand. One is that our adult immune deficiency patients should be in screening programs like everybody else. For the screening programs for prostate cancer, breast cancer, all of those things. They're not necessarily because they've got a specific risk, but because they should be screened. There is a killed preparation of varicella vaccine given to older people in many countries. Our patients broadly should be getting that treatment. And there are other killed vaccines coming in for things like RSV, which is a respiratory virus, that again our patients should be getting. So I think some discussion with the immunologist about what are the vaccines that I should be getting if I'm an older patient with immune deficiency. So their immune deficiency is likely not to be their only condition, because patients will get other problems like cardiovascular disease. So I think actually one of the important things that we understand at this point is that there needs to be a good dialogue between clinicians managing patients as they get older. And then there are different types of discussions that need to be had as patients come towards the end of life, which might be things like, do they want to continue their immunoglobulin treatment? Do they want to have it in a different way? Are there end-of-life decisions that should be discussed to respect a patient's wishes as they get older and come to the end of their life?
These are the everyday realities that rarely make it into medical charts. Across countries and ages, people with PIDs continue to navigate complex journeys. Their voices lead us toward greater awareness, understanding, and support.
Si pudiera mandarle un mensaje a las personas que son pacientes con inmunodeficiencia, les diría que no permitan que la enfermedad los defina como personas, sino que es una característica más, como tenemos todos, como el color de pelo, color de piel, etc. Y que al final lo que se termina definiendo como persona es lo que uno hace con eso.
Il faut être patient, s'entourer de gens bienveillants et qu'on peut toujours s'en sortir. Il faut pas déprimer, ça arrive, on n'est pas parfait. Et puis la maladie, en soi, on ne la choisit pas. Donc,
Je suis bien entourée de ma famille, je gère bien ma vie, je suis heureuse et je sens que chaque jour est un cadeau. Pour cela, j'en profite bien.
Patients with primary immunodeficiency can live as good as happy as many of their friends and their other family members. And we do emphasize that to them.
You want to make an alliance with the patient and the family so that it would provide the best level of care for the patients, and the patients will feel, and the family will feel more involved and concerned.
I mean, I'm really pleased to say that many adults with immune deficiency, the majority, can live very full lives.
I think the importance of patient organizations is it's easier to get the numbers through them, because for example, Yara's case, the doctor is the one who guided me towards a patient organization, and before that I felt like I was alone. But when I joined the patient organization that I am affiliated with at the moment, you realize you're more. And maybe if we came together and have the right numbers, and this can actually happen through the patient organizations, then we'll be able to rally up and advocate and lobby.
APOPI's mission is to allow early diagnosis and personalized care for every single patient affected with PID throughout the world. And so we want to cooperate with all the stakeholders in the field, meaning our patient organization to begin with, then the physicians, of course the industry, regulators, every kind of decision maker that can help the patient access to their diagnosis at first and the treatment to follow. Join us to raise awareness, to promote education, and to ensure ultimately that every single patient in the world affected with a PID gets an early diagnosis, an appropriate treatment, and the appropriate management.